Um, Thank you all. I am going to present my case. There will be two cases with HER2-positive breast cancer with de novo metastasis. First case, 34 years young lady with her pregnancy and its third trimester came to us with her complaint, and she had no comorbidity or related family history or personal history. Sir, from my panel of experts, I want to know from my medical oncologist panel, Dr. Don and Dijon sir, to put some comments to enlighten us about the management, about to address the case in breast cancer in pregnancy. Can you explain? What will be our management? I'm first taking that it's a malignant case.
Well, I mean, I think a couple of things. We see it. It certainly happens. If it's in the first trimester, it's probably the most complicated time to figure out what you want to do with that cancer, because when it comes to medical therapy, you can't use treatment in the first trimester. There's some, actually, I'm part of a panel at the American Society of Clinical Oncology. We're going to be releasing clinical treatment guidelines on pregnancy this year that actually will contain all of it. You cannot delay the workup of a woman who is pregnant presenting with a mass. Whether or not pregnancy accelerates the growth of a breast cancer, that's always a big concern that we have. But the delay of any treatment at all, or even the diagnosis, is a delay in diagnosis. Right? So if someone is coming in, like this woman in her third trimester, it is our responsibility to make a diagnosis.
Thanks, sir. That female, actually, she had her valuable pregnancy, and she didn't want to go for any interventional procedure. So, initially, image was done to assess the condition of her disease, and it was ultrasound of both breasts, and it showed left breast a large mass replacing most of the breast tissue, irregular with prominent internal vascularity. Left axilla, multiple enlarged lymph node, thickened cortex. Largest one, 2.7 by 1.8 cm. Right breast and axilla was negative. We did core biopsy from that breast during her pregnancy, and it shows invasive ductal cell carcinoma, grade 2, no risk factor during the biopsy was found. Her immunohistochemistry showed ER negative, PR negative, HER2 3 plus, Ki67 was 30 to 50%. We did her marker, and it showed CA1 5.3 is 293. Now, as because she didn't want to go any test further, and she wants to continue her pregnancy. If we go for it, we know that in third trimester we can continue our systemic therapy. What will be the option to select? Sir, again, from medical oncology panel.
Did you not biopsy the lymph node?
Sir, we didn't do biopsy from lymph node. It was not done that time, and I am coming later because it already locally advanced. It was because that time it was engorged, and ultrasonography I am first showing that a large mass replacing most of the breast tissue. We thought, we assumed that it exilum because it was multiple heart, it may be metastatic clinical. And it was locally advanced case with pregnancy and breast engorgement. And she didn't want any further intervention.
The reason I bring up the lymph node biopsy is that if you biopsy flipped liver and then she converted from clinical positive, clinical negative to systemic therapy, that would have impact on local therapy.
Definitely. So we're coming to that. We're coming to our image later because initially she just continued her pregnancy, and after that she done all this and come. So, from my medical oncologist, can you please enlighten what will be the choice of systemic therapy first?
Yeah, so the only drugs you cannot give in pregnancy are the anti-HER2 drugs. You just cannot give it. It can cause yes, that. And it can actually cause fetal harm, no matter what. Adriamycin you can give in pregnancy. Cyclophosphamide you can give in pregnancy. This guideline is going to suggest that Taxol is safe during pregnancy as well. So those are your choices. You can give carboplatin as well during pregnancy. So chemotherapy is okay. Any targeted therapy, tyrosine kinase inhibitor, antibody drug conjugate, cannot give it in pregnancy.
Thank you, sir. So,
did you treat the patient during pregnancy because it was already diagnosed by biopsy?
Yeah, ma'am. We treated, actually she treated her chemotherapy during pregnancy, and it was treated outside, and she took only 2 cycles weekly paclitaxel, and it was used before delivery. And her delivery was done by C-section at her 34th week. Sir, from our panel of experts, I am coming to Ismail Chakri, sir. Which time after in postpartum to do scans, and which scans to be preferable in that time in her postpartum period? Can you enlighten us?
So just remind me, did she start chemotherapy before the C-section? She did?
Yes.
Yes. How?
2 weekly paclitaxel. 2 cycles for 2 weeks. 2 weeks.
Before she had her C-section?
Yeah. And it was treated outside.
Yeah.
Outside of the country.
So I actually don't think you should have scanned her at all. Because after 2 weeks, what are you looking for? I mean, I guess you could have looked for metastatic disease. If that's the reason. But if you're looking for
it
any
was
kind of...
not yet before proved that it was metastatic. It was diagnosed case of breast malignancy, and after scans it was done after delivery in her postpartum period. It showed, I'm coming in
Yeah, no, I'm just saying, my point is I'm not sure why you imaged her so soon after postpartum. If it was for staging, that's one thing. But if it was for response, you were never going to see it after 2 doses.
No, only 2 cycles we for staging purpose, not for response.
Yeah.
Definitely, because the image could not be done, and patient didn't want to do image at that time.
Yeah, I mean, I
From
think
patient concern.
once the baby is delivered,
Yeah.
you can scan anytime.
Yeah. Okay. That means in postpartum there is no issue with engorgement. Then her scan was done, and it showed locally advanced heterogeneous left breast mass, size approximately 15 by 1.5 centimeter, with chest wall, pectoral muscle, and cutaneous disease involvement, multiple metastatic axillary and subpectoral lymphadenopathy, up to 1.5 centimeter in short axis, with metastatic hilar, mediastinal lymphadenopathy, bilateral lung metastasis, multiple hepatic metastasis, which you can see in the scans. It was her initial presentation after her delivery. our working diagnosis is moderately differentiated invasive duct cell carcinoma of late breast during pregnancy with metastatic lymphadenopathy with hepatic and pulmonary metastasis, hard to enrich subtype. Clinical staging is T4 N plus M1. We didn't do any further biopsy from any metastatic site. In case for metastatic case, genomic study was advised, but the patient didn't do that. What will be the treatment plan for this young lady? Can you say from my medical oncology study?
Yeah, I mean, I think
And what will be better?
we would give her TCHD.
TCHD.
Yeah.
TCHD, not TPH.
What?
Not TPH, TCHD and TPH both can be given or not.
Oh yes, well, I mean,
Right.
yes, I mean, if pertuzumab is an issue, then
It's a metastatic.
yeah.
Yeah.
Would you have wanted a biopsy of the metastatic site to prove that one? To prove that one?
Metastasis.
Well, if she's at metastatic disease, I don't think there's not going to be a for surgery.
No, but would you want a biopsy to prove?
I mean, I think that would think there's some imaging.
I mean, I said it this morning that my bias is always to biopsy first recurrent disease. But even in the case of someone so young who just had a baby,
Yeah.
I think it would be, it may be more helpful to biopsy the liver to prove it, especially for someone who may be dealing with a lot of regret that she waited so long.
No. So our aim was palliative settings, and we gave her docetaxel with trastuzumab and pertuzumab, that is TKHU, and we completed 6 cycles, and with cycle evaluation was done, and as usual it showed partial response. And she took her chemotherapy with anti-HER2 till May 2024. Her post-chemo evaluation after completing 6 cycles of chemo with anti-HER2 showed stable left breast mass with diffuse overlying skin thickening as before, hypoattenuating suspicious lesion in the liver in multiple segments decreased compared to prior with partial response in mediastinal hilar lymph node. We also did some subsequent scan. At this moment, what will be, we all know about that. In general, for other than medical oncology, what will be the maintenance phase for this young lady?
So I think we have to be very careful about language. I typically think of maintenance when I maximize the treatment, when you get the best response possible, and then the subsequent scans there's no further change. When you get to that plateau, that's when I bring in the term maintenance. She's responding.
She is responding.
So I would not change her therapy.
Right.
Which is problematic with docetaxel. Because docetaxel is not a drug that someone can remain on long term. I think the most I've given it was for sarcoma, and I think I gave about 28 cycles.
Docetaxel.
Yeah. Pleural effusions, it will close off the lacrimal duct, so people will have excessive tearing, to the point where the ophthalmologist might have to put a stent. This is a very toxic drug long term. But for someone who's responding, and I assume is tolerating it, I would not change her therapy. I would not stop the chemo.
Then we will continue chemo with anti-HER2, right?
And then you scan at 8, 12-week intervals. And once you get that point where the response is maxed out, then you put her on HP.
We continued her treatment with PHU.
And we saw the women who were dying in their beds, and they got trastuzumab, and they woke up, and they went back to work. They talk about a Lazarus effect. This drug caused the Lazarus effect. You stop it, she'll be right where she wants to be. There's no endpoint in metastatic disease. If she cannot afford it, that's different. I'd probably switch her to trastuzumab alone. But you don't stop it if it's an option.
Can I interpret? If in some time, in some steps of her life, when she will recur, it's okay, she will then recur. But if trastu a bit costly for that patient, if it happens in later phases, what options we can choose further for that lady to keep her in well position? What options if yet she can't afford trastu also? What options you can choose? You see, you may think that she can't afford trastu also, but to not it can be done. Trastu also she can't afford. What we can think for next line for that in that case?
We are trying to get, and I think we might have, but we are trying to list trastuzumab on the WHO list of drugs that should be available across the world.
Yeah.
Because there are still places in the world you cannot get trastuzumab. Like it's not on the market in the country. So we are trying to correct that. If she cannot afford trastuzumab, if she doesn't have access to it, she's not going to be able to afford anything else. TDM1, TDXD, all of these new drugs
Too costly.
are far more
Too costly
expensive.
for us.
But and it's far more expensive than trastuzumab. Remember, when we used trastuzumab for metastatic disease, we continued the trastuzumab and we switched to chemo partner. Yeah, so if she relapsed on trastuzumab, pertuzumab, I would stop the pertuzumab, I would continue the trastuzumab, and I'd start chemotherapy again.
Okay.
Because financial talks is more here because patient have to pay from their own pockets for the antibiotic therapy.
Yeah.
And I think just because we
No
have these two
insurance
here,
because it's that.
I should also say, just because we have local treatment plays a role in metastatic breast cancer.
Yeah.
So say everything is stable, but a solitary liver lesion that's growing, I would actually get radiation oncology to see her.
Yeah.
Say, what do you think about localized therapy to a single lesion? I've been surprised that I can actually get people stabilized if you combine this approach.
So,
We do see patients with stable disease, stable metastatic disease. My experience is that if she's got symptomatic disease in the left breast, there's little point in giving a palliative course of radiotherapy because that doesn't give you curable control. But often if you give a radical course of radiotherapy, that can give you good symptomatic control for quite a long period of time, and that in conjunction with systemic control can be quite important.
so that in that phase we can for local control with local antidote. Okay, that's a good option for us. And
I think this is a good case for Bangladesh oncologists.
yeah,
Because
Yeah.
you are experts
We
in
are
both
facing this.
radiation and medical oncology. You have to think outside of the box for young women with breast cancer.
Yes, sir, and we have facing a lot of these patients, and today one of attendants of our patient is present here to know what options can be done, and he is also present here. It's really financial toxicity for us. Now I am going to my next case, and it's a bit like similar in some aspects. My case 2. She is 28 years old, lactating baby. She also came to us with her complaint with no significant comorbidity, family history or personal history. For her complaint, we do initial scans, ultrasound, and it showed multifocal lesion in lower medial quadrant of left breast with microcalcification with ill-defined border, with multiple lymph nodes in left axilla with thickened cortex. Core biopsy was done. It was infiltrating ductal cell carcinoma, and core biopsy from lymph node was done, and it also showed metastatic ductal cell carcinoma. Report was reviewed, and it showed the same except change of grade. Immunohistochemistry was done and it showed ER positive, PR negative, HER2 3+, and the report was reviewed. It showed ER 8 out of 8, PR 3 out of 8, HER2 3+. GATA was diffuse and strong positive. A marker was done and it showed 42. So we did her staging workup and it showed suspected bony lesion at D6, D11, D12, L3 and L5. Both CT scan of whole abdomen and CT chest both showed that.